Next we have Dr. Prerna Garg. She is speaking on Rho kinase inhibitors. Rho kinase inhibitors came just after the COVID wave, and they are being used abundantly now in certain cases and selective cases. To Prerna.
Yeah, so I'll be speaking about Rho kinase inhibitors. They were actually they were actually introduced in 2017-18. That is when they were FDA approved first. This is the basic mechanism. This is the trabecular meshwork, and these are the different layers of the trabecular meshwork. And as we can see, as it goes from inner to outer, the pore size decreases. So there's a funneling effect in the aqueous humor outflow. Now, why this is important is because this is where the Rho kinase inhibitors act. There are no other anti-glaucoma medications which act at this area, and this is the main area which is damaged in an open-angle glaucoma or why IOP rises in primary open-angle glaucoma. So in this, we can see that the intertrabecular spaces are actually decreased in a POAG case. And the cytoskeleton has large number of filaments, microfilaments and microtubules, including actin and myosin filaments, which make this trabecular meshwork act like a muscle type cell and is responsible for the contractile function. So it was thought that let's find some agents which are acting at this area and causing the trabecular meshwork cell to relax and increasing the intertrabecular spaces so that the aqueous outflow resistance decreases and there's more aqueous humor outflow from the normal pathway. So initially what they found was microfilament disruptors like cytocalicins and latrinculins. So, but this caused a very non-physiological damage to the trabecular meshwork cells. It increased the spaces, but it was very non-physiological. Similarly, latrinculins. Then protein kinase inhibitors which uncoupled actin from myosin were discovered, but they also were a little bit more physiological but not reversible. So then Rho kinase inhibitor, the first agent to be discovered was Y27632, which was found to have reversible changes in the cell shape, and it primarily acted on two parts of the actin-myosin fibers, the stress fibers and the focal adhesions, and both of these acted to increase the intratrabecular spaces. And it was found that actually the outflow resistance decreased by as much as 65% in the studies. So Ripasudil first received its approval in Japan in 2014, and Etarsudil received in 2017. And both these agents, they received approval for ocular hypertension and POAG. And Roclatin, which is a combination of Nitarsudil and Latanoprost, has gained US FDA approval in 2019. So the mechanism of action is basically on the TM and the Schlemm cells where they increase the aqueous humor outflow. But because they have a vasodilatory action, they also are neuroprotective and increase the blood flow or the ocular blood flow. Also because the first agent which was discovered in Japan, Fasodil, is known to have effect on cardiac fibrosis and hepatic fibrosis patients. It has anti-fibrotic effect. So it was speculated that maybe these drugs also might decrease the fibrosis following a trabeculectomy. Nitarsudil was found to have two additional mechanisms, a norepinephrine transport inhibition, which would further lower the aqueous humor production and also decrease the episcleral venous pressure. It has been found, it was discovered to have other uses in ophthalmology, like in corneal endothelium, where it has been tried in fuchs and endothelial decompensation following cataract surgery, and other areas have also been tried. So it is being used as a first-line therapy, not very frequently, but these are the phase trials which were conducted. In the phase 1 trial, surprisingly, they found that in normotensive individuals, the latanoprost xalatin was given. It decreased the IOP by 3 millimeters. Mercury, whereas Nitarsudil decreased it by 6 millimeter mercury. So then they went ahead with the other trials, and the rocket trials were the phase 3 trials which were conducted, which included 4 trials. And they found that it had all the different mechanisms of action. It did not cause any aqueous humor IOP fluctuation during the day, so it acted equally during day as well as night. And what was surprising was that while timolol and latanoprost had higher IOP lowering at higher IOPs, like in the range group after 22 millimeter mercury, this acted equally throughout the IOP. So it also had a higher IOP lowering in normotensive individuals with low baseline IOP. And the dosing at night was preferred because the conjunctival hyperemia, which is known with these drugs, disappeared during the night. Similarly with Ripasudil, all the 4 trials had a similar effect and found that the IOP lowering was in the range of 3 to 4.5 millimeter mercury. And the most common side effect, again, which was noted, was conjunctival hyperemia. But in both all the studies it was found, it was mild, resolved within 2 to 3 hours. It has also been tried as an adjunctive therapy with good results. And there are few cases in our center when we found that actually secondary open-angle glaucoma patients who were on maximal medical therapy, pressure was not controlled. When we started them on nitarsodil, 0.02%, it actually became in single digits. So this patient was a 12-year-old boy, status was corneal tear repair and 270-degree angle recession. We didn't want him to undergo a trab. We just tried nitarsodil. Pressure was not controlled on all the medical medications, including astazolamide. So, in 1 week when he came back for follow-up, IOP actually decreased, and it is like that. We have decreased the other anti-glaucoma medications and continued him on nitarsodil, and pressure is controlled, and he has not needed any surgery till now. Similar other patients, out of which at least few patients, 1 or 2 patients did need a surgery eventually, but in lot it has been controlled with nitarsodil in secondary open-angle glaucomas. So coming to the side effects, this was the efficacy which we found. Now conjunctival hyperemia has been very well reported. Other than that, in the rocket trials, cornea verticillata was reported in around 20% of the patients. Corneal or perilimbal microhemorrhages were reported. What we found in our center was the increased incidence of reticulocorneal edema with this drug, especially when it was used as an adjunctive therapy when the patients are already on all the AGMs possible. And it was seen that most of the patients, all patients had compromised endothelium at the site of this reticular edema, and most of the patients had angle closure glaucoma, mostly secondary angle closure, but also primary angle closure. So we just felt that maybe in angle closure we need a more follow-up. It was a reversible side effect. As soon as we discontinued the drug, it resolved. Other side effects which have been reported in literature with these drugs include a punctal stenosis, anterior subcapsular cataract, also one case of nitarsodil-induced corneal flattening of around 6.5 diopters, which reversed on stopping nitarsodil. So these are reversible changes. The nitarsodil-related eyelid wound dehiscence has been reported, allergy as with other drugs. This is one case of antineurotic edema which we saw, which might be due to nitarsodil. So the indications include as a first-line therapy, as an adjunctive therapy. In normal tension glaucoma, it might have a role because it decreases the IOP more at low baseline IOP as compared to timolol and latanoprost, but it has not been studied. In secondary open-angle glaucoma and post-trabeculectomy to decrease the fibrosis. I feel that it is not recommended in corneal decompensation when the endothelial cell count is low, and maybe in angle closure it can be given, but requires a good follow-up. Thank you.
Yeah, Dr. Prerna, thanks for an interesting presentation. You covered almost all aspects of Rho kinase inhibitors. I shall like to ask some people, they say, or mainly the representatives, they say that if there is corneal edema post-cataract surgery, then these drugs can be used. So do you agree to this?
Yes, ma'am. Actually, I think it depends on the endothelial cell count and specular microscopy. So studies have not been done till that level right now. We think that we have started doing specular microscopy before prescribing Rho kinase inhibitors now to have a study like that. But maybe in even Fuchs and corneal decompensation, when there's early endothelial cell loss, not very severe, in those cases it might be helpful. Haven't seen any results as such, but might be helpful.
Okay. And corneal edema, that microcystic edema that is found only with nitarsodil, or it is also seen with ripasodil?
Both. Mostly with nitarsodil, but nitarsodil is used with more higher frequency as compared to ripasodil. So in our case series, we have around 15-20. In those, 2 or 3 were with ripasodil, but it's not that it's only with nitarsodil. So there is some speculation that maybe ripasodil gets less absorbed and goes less in the anterior chamber, so there's less incidence. But we have found reticular corneal edema with ripasodil as well.
Right. So these are the 3rd or 4th line drugs and indicated in NTG or non-responding cases maybe. They have not found great place in glaucoma armamentarium till date. But yeah, we hope to a better future. So any questions from the audience? Yeah, sir has a question.
Yes.
Nitarsodil, these Rho kinase inhibitors have multiple mechanisms of action.
Yes, sir.
Like they decrease the aqueous production, they have the outflow resistance also they decrease, or they have a neuroprotection. Still the IOP lowering is 3 to 4 mm only.
So they also decrease the episcleral venous pressure, and that's why we found that sometimes with nitarsodil the IOP actually becomes in single digits. So with no other AGM we can see the IOP to fall below 8 or 10 millimeter mercury. But with nitarsodil we have found.
Recommended as first line therapy.
Not really, but the rocket trials recommended it as first line, but we are not using it as first line. Maybe we need studies for that.
Generally the first line drugs, especially the latanoprost or
Timolol.
Timolol, they decrease at least 1/3 of the IOP.
Yes. So the IOP lowering which they found in the studies was around 20 to 25%. So that is actually quite comparable to beta blockers, but we have not been
But
using
still
it.
the recommendation is not that
No.
they cannot be used
No.
as a primary
No.
single line therapy.
No, I don't think even in the European guidelines it's recommended as first line right now.
Thank you.